Good evening, everybody who are present in the today's meeting. I think there is a long gap between the previous class and now because of the national conference and the hernia conference. So I think Ajit will just give us a brief summary of where we were last time, which is the clinical presentation of the patient, and then we have discussed the presentation, the history and clinical examination. I think we will move to investigations and management. So that is what is left now, and so Ajit is going to start. I think I'm very grateful for the presence of all the senior teachers. Many of them are postgraduate examiners, so it is nice to have their views about what is current and what is acceptable in exams also. Okay, without much delay, I'll hand it over to Ajit.
Yes. Sir, is my screen visible, sir?
Yeah, it is. Go for the full screen.
Yes. So, good.
Yeah, for the benefit of the students, I think Dr. Lakshman asked these questions very specifically from the examiners, because I think it is one thing to know about something, but what is acceptable in the exams is what was very important for us. And basically, the in terms of presentation of history and clinical examination, the examiners do not expect you to list out all the features of hypo or hyperthyroidism, both in the history and clinical examination, and also the pressure effects, unless you have specifically have any of these either hypo or hypothyroid symptoms or signs. Then you are expected to elaborate on each of them. If they are not there, you can in one sentence say that there are no symptoms or no clinical features suggestive of hypo or hyperthyroidism, and no features suggestive of pressure symptoms. So I think that the student should be very clear about this. Now, Ajit, you please start.
Yes, sir. Good evening, respected teachers and my dear colleagues. Last time we had discussed this case of one 40-year-old gentleman with painless progressive swelling in the front and left side of the neck with no history suggestive of pressure symptoms or symptoms of hypo or hyperthyroidism or symptoms which suggested metastatic disease. On examination, there was a solitary non-tender soft swelling of size 7 into 5 centimeter, which moved on deglutition, and there was no evidence of retrosternal extension or cervical lymphadenopathy or metastasis. For everyone, I'll show the picture again. Sorry, sir. This was the swelling. Sir, actually, last time you asked us to elaborate on the eye sign, sir. So I put these pictures. Uh, in Mebius sign, we ask we make the examiner standing by the side of the patient. Hand is put on the head of the patient to make it steady, and patient is asked to look at a distant object. And when then the patient is asked to look at the finger brought close to the eye of the patient, and there will be failure of medial convergence on the in Mebius sign. While in Geoffroy's sign, it is positive when there is absence of a wrinkling of forehead on looking up, and in Stelvak sign, there will be stare look. Here we can see that the sclera is the patient will have proptosis, so the will get a look that the patient is staring at us. So that staring look is called as Stelvak sign. Then one graph sign. Here, examiner standing by the side of the patient, and the head of the patient is steadied, and patient is asked to look up. And when the patient is asked to look down, there is uh, if there is a lead lag, then positive Van Graaff sign is there. Now moving to the investigations part. In this patient, we'd like to get TSH, T3 and T4, ultrasound of the neck of the patient followed by FNAC, then uh, investigations for assessing the fitness of the patient for the surgery, uh, uh, chest, uh, chest radiograph of the patient, ECG. Because of the COVID times, we will get an COVID RT-PCR, and X-ray of the neck and indirect laryngoscopy to see the vocal cords. So, sir.
Yeah, continue.
So we did ultrasound neck of this patient, which showed that there was a cystic lesion of 55 into 40 into 46 size in the left lobe and isthmus extending up to the suprasternal region. Then there were another very small cyst with internal septations in the left lobe, and very few tiny 2 to 3 cysts in the right lobe. There was the thyroid capsule was intact, and a few sub-centimeter size lymph nodes were noted, which were not significant. So FNAC was done for this patient, and it showed colloid goiter with cystic changes. So we planned this patient for left thyroidectomy.
Okay, stop. Vanita, will you please tell us?
Yes, sir.
What are the features in ultrasound scan that you look for? I think Dr. Lakshman has very clearly stated this many times, but I just want you to repeat them. What are the ultrasound features you look for in a thyroid scan? What
Sir,
kind of ultrasound do you do? What kind of ultrasound?
Sir,
Anybody else? Hari?
Sir, high frequency, sir.
High frequency ultrasound scan. So remember, it is not rocket science. Any, the abdomen, thorax, when the deep cavities, you don't need to do high frequency. For surface lesions, you need high frequency ultrasound scan. Okay. Now, Vanita, please tell us, what are the features?
sir, we'll see whether it is a soft or soft cystic lesion or containing solid area, sir.
Okay.
Like the consistency of the lesion and the margin, sir, whether it is regular or irregular.
Okay.
And it will be thyroids, we will see, sir, like margins, consistency.
Saurav? Saurav, are you there? Janani?
Sir, yes, sir. Sir,
Yeah.
and also we will be seeing any nodules that are not palpable, specific.
Correct.
And also whether capsule is intact or any extracapsular invasion, extension of the tumor is there.
Okay.
Yes, sir. And it can also detect the enlarged cervical lymph nodes, sir.
Correct. And what in cervical lymph nodes tells you? What in cervical lymph nodes tells you that it may be malignant rather than benign? Are there features that you know that you can tell whether they are malignant or benign? I think again Dr. Lakshman has very clearly elucidated in his class.
Loss of phylum, sir. Loss of phylum.
Okay. Loss of phylum.
Corticomedullary differentiation.
Yeah, corticomedullary differentiation. Size of the gland.
Size. Yes, sir. Mated lymph nodes.
Yeah. Isolated, shorty, small lymph nodes are less likely to be malignant. Matted nodes, loss of corticomedullary differentiation, size of the gland, and then capsular invasion,
Vascularity.
and vascularity. All of these. Sir,
Sir,
Sir Gurushantappa, sir.
sir, shall I come in, sir?
Just a minute. Dr.
Yeah.
Gurushantappa wanted to add something. Yes, sir.
For all the postgraduates, this is one of the important question which is asked whenever you present a case of thyroid nodule. You need to know what are the right terminologies to be used whenever asked about sonography pertaining to thyroid disease. The consistency which you have mentioned, Dr. Lakshman has put in the chat box, you should not be telling it as a solid or cystic on a sonography. That is a clinical examination finding. So sonography will tell the
Hypoechoic.
echogenicity.
Yeah, hypoechoic,
Usually,
hyperechoic.
whenever we do it, so whenever we do a sonography, that is a thyroid sonography, echogenicity is compared with the side by muscle mass, that is sternocleidomastoid, and then compare with that echogenicity and conclude whether it is hypo, hyper, or isoechogenic. So depending on that, we take it as whether it is more towards a benign disease or a malignant disease. If it is a hypoechoic, more towards malignant disease.
Malignant.
And Ravi had asked again, what are the signs of the malignancy on ultrasound? This also, it is a commonly asked question, and all of you should know because you will be accompanying the patient for sonography with a radiologist. So you will have a discussion, and you need to know like what are the important points. First, you should know whether it is a purely cystic nodule or a complex nodule or a solid nodule. If it is a complex and solid, keep a possibility of malignancy. If it is a pure cystic nodule, like what you have presented just now, that makes a malignancy unlikely disease. It is around 1%. Second, comment about the margin. Is it regular or irregular? Irregular matters, otherwise called infiltrative margins, goes in favor of malignancy. More taller than wider, taller than height, more than the breadth, more in favor of malignancy. Fourth, if there are microcalcifications within the given nodule, keep a possibility of malignancy, more so papillary carcinoma. Then the lobulated surface, microlobulation, they are called microlobulations on sonography, goes in favor of malignancy. Halo around the nodule, point in favor of malignancy. Increased vascularity, if you put a Doppler for sonography, if it shows increased vascularity, keep a possibility of malignancy. So I expect from the postgraduates all these points in the same order, preferably, so that you finish off that nodule first. These are all the points pertaining to the nodule. Then go to the remaining gland, that is, which are not clinically felt, can be seen on sonography in the opposite lobe or by the side of this nodule in the same lobe. That becomes, if that is a finding on sonography, this given nodule becomes a clinically dominant nodule. Means the other nodules are not felt, which are picked up on sonography, and this is the solid nodule you are feeling. So that becomes a clinically dominant nodule. So that is the important. Then go out of the thyroid gland, look for the lymph nodes. So presence of lymph nodes in a thyroid nodule makes malignancy a strong possibility. Again, you should know what are the classical features of a lymph node if it is a malignant metastatic node. So this is exactly you should go whenever sonography is asked pertaining to thyroid. Nodule first, next gland, then the blood vessels, carotid and IJV, then the presence of lymph nodes. So Ravishankar, I think I have made it clear in the same manner you should know and describe and put repeatedly so that you will remember the things.
Yes, sir. I think that is extremely helpful. So postgraduates, I think you must write down these things very carefully because it is not just because sir has said it, but because there is a logic to the way he has actually presented it. So, and it is also probably easier for you to remember gland first, the nodule first, gland next, and then the rest of the thing, which is lymph nodes, carotid vessels, and internal jugular vein. So remember this, then you will not usually miss it. Okay. I think we have covered the ultrasound. Dr. Lakshman sir, have you got anything to add, sir?
No, I think this is a juncture where they can talk about the thyroid function tests and the role of free thyroxine, free T3, free T4 versus the routine thyroid function tests. Ajit, can you expand on that?
Sir, actually, if TSH is normal, sir, then there is no need to do this T4 T3 test, sir.
Okay, I'll buy that. Okay.
Yes, sir.
No, but I'm not talking about only T3, T4. What is the difference between the standard T3, T4 that we get in the lab and the free T3 and free T4 that we get? And in what clinical situation is this important?
In case of sir, thyrotoxicosis or hyperthyroidism,
Okay.
we'll have to get free T3, T4, sir.
Always.
Yes, sir.
Please look up the literature. I
And,
can give
it
you
is-
the answer, but I would not like to, because you must do some reading yourself. What you have said is incorrect.
Yes.
All right. So
Not all.
you must know, all of you. Please look it up and in fact put it up in our chat or whatever, in the group chat. What is it that, when is it that you would really like to get the free T3 and T4 versus the ordinary T3, T4? Okay.
Dr. Gurushantapa has put up a question. What is Thyroids?
Yes.
Anyone?
Sir, thyroid image reporting and data system, like Byrads for breast, sir.
Like pirates.
Yeah.
So, sir, there are 5 with this one, sir.
Yeah.
So, first is 0 points, sir. Stage 1 thyroid. So it will be according to the things we have mentioned before: composition, shape, then calcification. So, and height, taller or wider, taller more than wide. So there are 7 points. 0 is 1, 2 type 2 thyroids 2 is 2, thyroids 3 is 3, and more than 3 is, and less than 7 is 4, and thyroids 5 is more than 7 points.
Okay. So that goes from benign to malignant.
Benign, yes, sir. So that will be first will be benign, then not suspicious, mildly suspicious, moderately suspicious, and highly suspicious.
Okay. Now
Ajit,
Ajit.
yes.
Yeah, in
Yes, sir.
what we explained, no, sonographical features of malignancy.
Yes, sir.
Thyroid sees, it will identify, but ultimately the grading is done 1 to 6, 1 to 6, and he will not put these findings into that. From 1, it is towards benign, 6 is malignant.
Yes, sir.
In the middle of this intermediate, then he will have 1 on either side, then becomes suspicious of malignancy in a benign, then here suspicion of malignancy and approved malignancy. You got the point, like that, and you put the features of malignancy on ultrasound later. So in thyroids, it is classified 1 to 6. He will not take directly taller, calcification, the infiltrating. He will not take in that classification. He will grade that for the malignancy. You got the point. So number
Yes.
1 is thyroids. 1 is, it is benign, purely benign. There's nothing.
Yes, sir.
It is absolutely benign. 6 is, it is malignant on sonography, malignancy. Okay. Then second is, there is some amount of suspicion. You
Okay,
got
sir.
the point, like
Yes.
that. So like that, it is classified. These
Okay, sir.
directly, these findings are not put into that. Okay.
Okay, Hari, we have now finished the thyroid, ultrasound scan. What, Ajit, because you are presenting, I'll ask you, is
Yes,
Saurav there or not there? Saurav not there?
Sir, he was here, joined. Maybe some points, sir. I'll ask him.
Okay, Saurav is not answering. And Ajit,
Yes, sir.
what are the indications for radionuclide thyroid isotope scan? Let us say you've got a thyroid nodule. What are the indications where you want to do isotope scan? And what are the
Sir.
principles? How do you do it?
Sir, system AB scan will do, sir.
No. Not system AB. System AB is parathyroid. You don't know radioisotope thyroid scan?
Yes, sir. I-123 scan, sir.
Yeah. And what else?
Uh, I-131, sir.
I-131. What is the difference between I-123 and I-131?
Sir, I think I-123 is not available in India, sir, like that. You
Yeah,
had
but
told
that is
in
not the
last.
difference.
Half-life, sir.
What is the difference?
Half-life, I-131 half-life 8 hours, I think, sir.
Huh.
I-123 half-life 2
Hello?
hours, I think, sir.
Yeah.
Hello?
Okay. Huh.
Sir, hello, am I audible, sir?
Yeah, yeah. Okay. So you're there. See, the
Yes, sir.
I-123 has a shorter half-life and usually used for diagnostic purposes. I-120, I-30, I-131 is used for therapeutic purposes. But in India, because I-131 is the only isotope available, so we use that both for diagnosis and therapeutic purposes.
Yes.
And as Lakshman has indicated, this one is technetium pertechnetate scan. There are many others, but the commonly used ones are iodine 123, 131 and
And technician, sir.
technetium pertechnetate.
Yes.
So what are the indications for doing a thyroid scan? Saurav, can you answer that question?
Yes, sir. Sir, in a patient with probably a nodule that is identified in an USG,
Yeah.
with a patient with in a patient of hyperthyroidism,
Okay.
in those cases we can go for a technetium scan to identify the uptake, whether it is taking uptake or not.
Yeah.
Uh, in cases where there are multiple nodules in the thyroid identified on USG, we can go for a technetium scan to identify which one is the hot nodule or if there is any presence of cold nodules.
Okay.
So it can direct our further investigations according to that.
Okay.
And,
Sir, in cases of if there is a recurrence, we then we but if you have put the patient on thyroxine, then before getting the radioisotope scan, we have to stop it around 6 weeks for
No, no,
the
no.
scan.
See,
And
don't
no.
confuse. Don't confuse. See, whenever you have operated and done a total thyroidectomy in patients with malignancy, then you want to see if there are metastatic deposits. So then you stop thyroid supplementation for a period of maybe 3 to 6 weeks, depending on the TSH levels. So higher the TSH level, the better. So when the TSH levels are high, that means the nodules which are likely to be metastatic deposits will become avid or hungry for the isotope. And so when you do a I-123 scan, then you will pick up metastatic deposits which are there. So that is another indication for thyroid scan. And the final indication will be if congenital defects where a mediastinal nodule is detected on a CT scan or a CT scan especially, and you don't know what it is. So, and if there is no thyroid uptake in the neck, then if you do a I-123 scan, then you will know whether this mediastinal goiter is a true retrosternal goiter. So these are the indications for isotope scan. So anybody have any other
sir,
indications? You can
I
tell
have
me.
one doubt, sir.
Yeah.
Sir, they have told that 6 weeks before we have to stop this thyroxine, and after that we have to give T3 for 1 week, and then 1 week before the scan, nothing to be given. So
No, I don't think that is the case. I think you should just stop and then you do the I-123 scan. If
okay,
you have, otherwise you do a I-131 scan. I don't think you should give T3 or anything. That is as far as I know, unless somebody else knows differently. So that's what Balakumar said, ectopic thyroid. That's what I meant. Some lingual thyroid or true retrosternal goiter. To pick up these things, thyroid isotope scans are useful. Yes, sir.
yes.
Okay.
Yeah,
Now,
Ravishankar.
yes, sir.
Yeah, that what Ajit or someone who asked, no, like T3, what he was asking.
Yeah.
See, what Ravishankar said, like 6 weeks minimum sometimes you may have to stop for 3 months and see that the TSH is up to 30 international units, minimum 30 international units, so that it will push whatever the iodine you are giving into the deposits, and that can be picked up on a nuclear scan. In this period, if the person develops the features of hypothyroidism, because you have stopped for 6 weeks or sometimes 3 months, so if he develops hypothyroidism, which are symptomatic, then T3, what you are talking, injectable form given for some days to treat that hypothyroidism, which is routinely not required in all the patients. So
Yes, sir.
6 weeks period stoppage will suffice and can be done.
Yeah, correct.
If that is the case, then immediately if you want to do it without stopping thyroxine, which you are supplemented, straight away you can give recombinant TSH and then submit the patient for nuclear scan.
Yeah. Okay, so we have discussed in this particular patient, we don't need to do isotope scan, but ultrasound scan. Hari, can you tell us what are the things you are looking for in an FNAC? What is the use of FNAC in thyroid swellings?
Sir, first it used to differentiate between benign and malignant nodules, sir.
Okay.
But it is hard to differentiate between vascular capsular invasion and FNAC, sir. But if possible to differentiate between benign and carcinoma.
Of what variety?
Follicular is difficult, sir. Can't be differentiated in FNAC.
Not difficult. Follicular is impossible.
Impossible.
Follicular. It will only tell you whether it's a follicular adenoma.
Yes, sir.
So you can't differentiate between adenoma and carcinoma, but papillary it can tell you. What else can it tell you?
Sir, colloid nodules and
colloid nodules. Can he not tell you about anaplastic?
Yes, sir.
Can it not tell you about Hurtle cell?
Yes, sir. It can differentiate between the thyroiditis and other possible differential diagnosis, sir.
Yeah.
Yes, sir.
So
Sir,
what are the? Tell me how do you do an FNAC? Ajit, tell me how do you do an FNAC?
Sir, if the nodule is very small, then we have to do ultrasound guided FNAC, sir. Otherwise, if it is large enough which can be seen and felt, then no need of ultrasound.
Wrong answer.
No, sir. No, sir. No, sir.
Wrong answer.
Sir.
Wrong answer. Okay.
Sir.
Saurav, tell me.
Yes, sir. So preferably, sir, we should go for an ultrasound guided FNAC, sir. Only if the USG scan is mentioning that it is THY1 or 2 or above. If it is THY1, there is no role for FNAC, sir, because mostly it will be benign. TH1, 2 and above, we have to go for an FNAC. In those cases, sir, USG guided is preferable because we can identify the most representative site on the USG. Correct. And take biopsy from there.
Yeah, that is important. So it is always preferable to do an FNAC under ultrasound guidance because you will get the most representative area for you to sample. And one more, this one I forgot, is medullary carcinoma. Even medullary carcinoma can be picked up by FNAC. Balakumar, thank you for that feedback. Okay, so what are the prerequisites of a good FNAC? Ajit? Ajit, can you hear me?
Yes, sir. Yes, sir. I can hear you, sir.
Yeah. You went silent, so that's why I thought I was not audible.
Sir, a good ultrasonologist will need, sir.
Yes, good ultrasonologist. Yes, good ultrasonologist, and more importantly, a very good
cytopathologist, yeah,
which are very rare. See, that is the problem. You need good cytopathologists who are very interested in and who are competent. So that is very important. So those two are prerequisites, and apart from that, you should get a good tap. It should not be a bloody tap, and there should be plenty of cells so that you can interpret it and you preferably you should get the sample from the most representative area of the thyroid nodule. Sir, Gurushantapa sir, anything else to add to the FNAC, sir?
Whenever FNAC for thyroid is asked, I think they should be mentioning USG guided. There is nothing like palpable FNAC for a
Correct.
thyroid nodule,
Correct.
always,
Yeah, always
irrespective
USG
of
guide.
the size.
Always USG
But
guide.
FNAC for other swellings, if it is asked, other swellings,
Yeah.
too big a nodule and too small a nodule are an indication for USG guided FNAC in other areas. But for
Okay.
thyroid, it is always USG guided.
Right. Dr. Lakshman sir, anything to add?
Nothing to add. Nothing to add.
So we have done the thyroid function, we have done the ultrasound scan and FNAC. Now this is a colloid goiter according to you, Hari. Sorry, Ajit. So what are the options? What
Yes,
will
sir.
you tell the patient, and how will you counsel the patient about what is your future course of action? Talk to me as if you talk to the patient.
Yes, sir.
Ravi Shankar, before
sir,
treatment, shall I just,
Yes, sir.
Ravi
Yes,
Shankar?
sir. Please, sir.
Yeah, Ajit,
Yes, sir.
you have done TSH and there was a discussion on nuclear scan for this patient, which
Yes, sir.
clinically you have diagnosed as a solitary nodule thyroid.
Yes, sir.
Will the TSH values decide whether this patient should be submitted for a nuclear scan? You understood the question?
Yes, sir.
Does this TSH values guide us whether this patient should go for a nuclear scan or not?
Sir, I don't know the answer, sir.
Okay.
Saurav,
I
do you
will give
want
a
to
scenario.
take
If
Saurav, do you want to answer that question?
Yes, sir. Sir, I think that, sir, in patient with a solitary nodule with a hyperthyroidism, we can go for a nucleotide scan, sir. I'm not sure, sir.
yeah,
What?
very,
Sir.
no, it's right. When
Yes. Okay.
TSH is too low, indicating that patient has got hyperthyroidism
Yes, sir.
with a solitary nodule. Your case is a solitary nodule clinically, and sonologically also it is a single nodule in the right lobe. Okay, so in a case of solitary nodule, if the TSH is low, even symptomatically patient may not be thyrotoxic. If TSH is very low, so that becomes an indication for a nuclear scan to know whether it is a hyper functioning nodule. Nuclear scan. Okay, if it is a hyper functioning nodule, what will be the reading in nuclear scan?
So it will be a hot nodule, sir. Hot nodule, sir.
Hot nodule.
Yes, sir.
Hot nodule. Very good. What is the meaning of hot nodule?
Sir, so the entire tracer is being uptaken by that single nodule, sir.
The rest of the gland is suppressed.
Yeah, remaining gland is suppressed.
Suppressed, yes, sir.
Remaining gland is suppressed. Oh, fine. Please continue.
Sir, and sir, hot node means cold nodule will be more for this suspicious for malignancy, right, sir?
Correct.
The percentage given in textbooks is to 10 to 20%, sir.
Cold nodules are more likely to be malignant compared to hot nodules. Very rarely do you see a patient with cancer who is thyrotoxic or hot, presenting with a hot nodule. Okay, so now you have clinically made a diagnosis of a colloid goiter. The thyroid function is normal, and on the ultrasound scan is what you have shown, and FNAC shows it's a colloid goiter. So now the size of the swelling is what, 5 by 6 centimeters?
Yes, sir.
Okay.
7 by 5.
Yeah, 7 by 5 centimeters. Okay, so what will you do? How will you counsel the patient?
Sir, we'd like to do a left hemithyroidectomy. Then
Why do you want to operate at all on in this patient?
sir, because he does not have any compressive symptoms or symptoms of hyper or hyperthyroid, but because of the cosmetic appearance, he has come to us, sir. Because
Is
of
that good enough indication to operate? I think I think examiners always expect you to justify your offer for surgery and cosmesis comes last in the indication.
Okay, sir. Sir, yeah, even if there is a chance of it going into malignancy on long standing, sir.
Of colloid goiter.
Yes, sir.
I'm not sure whether colloid goiters, of course, multinodular goiters can go into. So this one is a solitary nodule, so very unlikely. So what is your justification for operating? Has the swelling increased recently in size over the last few months?
Yes, sir. It has increased, but
So that you should quote as
yes,
the, so a swelling which was there maybe static or very slow growing has started increasing in size recently. So that may be the indication for surgery.
yes, sir.
Of course, cosmesis is, especially in
Yes,
women, but I don't think you should quote that as the first indication for
yes,
surgery. Okay, so what will you tell the patient? What are you going to do?
sir. We are going to do left hemithyroidectomy, sir. So
Okay.
and then we'll send the specimen for histopathology,
Huh.
and upon the further management will be depending on the uh, histopathology report. And
So this is a, according to the ultrasound scan, this is a cystic nodule, right?
yes, sir. Yes, sir.
Will you not consider any other option?
Sir, the aspiration of the cyst is mentioned, sir, but because of a recurrence, it is not usually done, sir.
I,
3 times they say that minimum 3 times it can be done. After that, you can directly go for hemithyroidectomy.
yeah, but see, you have to, I think if it is a purely cystic nodule, then there is definitely a role for aspiration and observation. If
Yes,
the cyst refills very quickly, rapidly, over the next 3 months or so, then I think that may become an indication for surgery. But I don't think straight away with a purely cystic nodule you need to offer surgery. In case there is hyperthyroidism or thyrotoxic features, then it's a different aspect. Otherwise, you don't need to offer surgery in the first place. What is your view on that?
Yes, sir.
yes,
Sir,
Ajit?
one more doubt, sir. Sir,
Huh.
if that cystic nodule in case of a male patient, is it like indication, sir, or it is like same for the normal? I think
I
this is
don't
the male patient, sir. Male
I don't
patient.
think cystic nodule in a female or male makes any difference. I
Okay.
think they are the same. It's only the cystic nodule, the size of the nodule, and how fast has it refilled. If you aspirate it and it fills up again very quickly, then you need to think about surgery. I think you can only give a trial of 2 aspirations, and if more than 2 aspirations are needed, then you should consider surgery.
Okay, sir.
okay.
So how will you counsel this patient? So you have now decided you are going to operate. I think Vasant Kumar asked that same question. Is surgery the only option? I don't think surgery is the only option. You should definitely aspirate the cyst if it is a purely cystic swelling. It is only different if it is a mixed echogenicity. If it is mixed
Complex cyst.
echogenicity, or if it's a complex cyst, for multiple loculations or solid elements in a cyst, such cysts should not be aspirated. You only aspirate it for diagnosis,
Simple.
which is an FNAC. So ultrasound guided FNA of solid area should be done, but you don't need to therapeutically aspirate them. But if it is a pure cyst, pure cystic swelling, then definitely a trial with aspiration can be done before you consider surgery. Okay, if you consider surgery, what you said, left hemithyroidectomy.
Yes,
Counsel the patient about how you do a left hemithyroidectomy, what are the complications, what are the problems, and how will you tackle them?
yes, sir. sir, we are hello. Hello.
Yeah.
Sir, we are going to get the left side of the gland and the middle part, that is the isthmus, out. There is chance of bleeding intraoperatively, as well as a chance of injury to the recurrent laryngeal nerve. Then post-operatively, there is chances of hematoma post-op bleeding, which can give rise to a compression on the trachea if there is more bleeding, and sometimes we may have to do a tracheostomy or re-explore the patient in case of bleeding. And if we are in this case, we are going to take only half of the gland out, so there is a very minimal chance of hypocalcemia, but still we'll take precautions for that.
See, what I am very surprised is neither Ajit, you or Saurav has mentioned anything about the AMES or AGES criteria, which Dr. Lakshman has very kindly pointed out about the indications for surgery. See,
Yes, sir, I
this
can say.
this nodule is 5 by 6 centimeters, right?
Yes, sir.
So does it not meet the criteria for surgery?
Yes, sir.
Then what? See,
yes.
that is how you have to answer a question. You have to always, give evidence based indications for surgery, not just something that you feel. So, what is the AMES and AGES criteria? Does anyone know?
Age, then grade, whether it is well differentiated or poorly differentiated. Then E is extension, sir. That will be either intrathyroidal or extrathyroidal, and S is the size, sir.
Yeah. So, according to this, age of the patient is how much?
45.
Okay. Is that
yes?
So? Does that come in the criteria
yes,
for surgery?
Yes, sir.
Okay. And then grade, we don't know. This is a benign thing, and size is definitely one of the indications for surgery. See, this is how you have to justify doing surgery in this patient, not just saying something.
Okay.
And I think you talked about thyroid compression. The tracheal compression and all that. I don't think that is that usually you should talk about in a hemithyroidectomy. Definitely hematoma, bleeding, and all that. But compression on trachea is quite rare in a hemithyroidectomy compared to a total thyroidectomy. What are the situations where you would request a frozen section biopsy on the table?
Sir, when we get FNA as follicular adenoma, sir, then on excision, on doing hemithyroidectomy, we have to get a frozen section, and depending on the report, whether if it says a follicular carcinoma, then we have to go for a total thyroidectomy, sir.
But how good is a frozen section in identifying whether it is a follicular adenoma or follicular carcinoma? Do you know the principle of frozen section? Anybody? Saurav, what is the principle of frozen section?
So we have to rapidly freeze up the cells so that it will crystallize and then observe under a microscope, sir.
So what is that instrument called?
No, I'm not sure, sir.
It's called a cryostat. So cryostat is an instrument used to rapidly fix the tissue. See, in the normal histopathology, you gross the tissues and then you take a period of 24 hours or so to fix the tissue in formalin, and then and then section it and then observe it under microscope after staining it. But in a frozen section, you use the cryostat, which freezes the tissue and fixes the tissue rapidly, and then it becomes hard enough for you to make sections and observe. I think I would request others to correct me if I'm wrong, but I don't think it is as good as a final histopathology for differentiating between follicular adenoma and carcinoma. I think it may be about 70 to 80% as good as the final histology. So so it is still very difficult to just go by a frozen section. If it says yes, there is it's a carcinoma, yes, you go by it and then do a completion or total thyroidectomy. But if it is negative, then it is still not clear whether it is still a follicular adenoma or a carcinoma. Sir, Guru Shantapa sir, can you kindly come in? Yes, sir.
Yeah. First, about the frozen section in thyroid diseases is not a very well accepted entity, and we usually from the postgraduates we don't bring this discussion.
Yes.
It is not a very well accepted entity in thyroid diseases.
Yeah.
The point is, if this nodule, you have done a hemithyroidectomy and the post histopathology comes as a histological surprise, as a malignancy, like a papillary carcinoma, then what is to be done? I think we can have a discussion with the postgraduates, because a frozen section is not a very ideal way of doing in thyroid, because false negative entity is very high.
Very high, yeah.
And the second, those according to my knowledge, these ages criteria are histopathological criteria. You have done a hemithyroidectomy for a case, and then histological surprise comes. For further treatment, you group that patient under these criteria into high risk and low risk. So these are the criteria. EAMS and AHS criteria is taken, and the patient is grouped or categorized into high group or a lower group, depending on the histopathology, age, sex, extent of surgery, and size of a nodule in a specimen. Then take the decision of doing further, whether to be managed conservatively or to be intervened surgically further.
Okay. Sir, Lakshman sir, anything to add?
Between the two, only one of them takes in the grade. But the fact is that if somebody has a nodule which is more than 4 centimeters, is a borderline age, and is a male particularly, then you are justified in quoting that as the reason for surgery.
Yeah, and about frozen section,
and
sir?
Frozen section, the false negative rate, depending on the center, is about 5 to 10%. And so you can have to take a call whether that is a high or a low figure. 10% can be considered high. But at the same time, while explaining its limitations, if it does say that it is neoplasm, you will avoid a second surgery for the patient. So if the facility is available, I would go for a frozen section. But again, as Dr. Guru Shantapa pointed out, it's not done very commonly, facility not easily available, and it does need a very committed histopathologist. But if it's available, it's not wrong to do it. And with the proviso, you'll have counseled the patient preoperatively that there is a 5 to 10% chance that that is wrong. And even though we close the patient, for example, based on the frozen section, there can be a histological surprise. And then you have to go for completion thyroidectomy, depending on what the histology is. And that's the discussion that we're going to have now, subsequently. Yeah.
Okay. So I think postgraduates, you're all clear. In the exams, you should say that frozen section is not usually very reliable as far as thyroid is concerned, unless you have a very dedicated, histopathologist. So you would not consider doing a frozen section in routine circumstances. But if you do have a good histopathologist, then it is certainly something that you should consider. But with the provision that there is a 5 to 10% chance. I thought it was slightly higher, but I stand corrected, that it's 5 to 10% chance that it will be negative, false negative, and then you may have to offer a further surgery depending on the final histology. So you have done a left hemithyroidectomy, Ajit.
Yes, sir.
So comment on the histology. What are the things that you look for in the histology, and what makes you worried?
Uh, Sir, vascular and capsular invasion, sir.
So what does that indicate?
Sir,
Usually you see that in vascular and capsular invasion, you see
carcinoma, follicular carcinoma.
Follicular.
follicular carcinoma. Okay, so if it is a follicular adenoma, if there is capsular or vascular invasion, then it becomes a follicular carcinoma. What about papillary carcinoma? What are the things that you look for in papillary carcinoma? Can you give me the sort of histologic features of a papillary carcinoma? Anybody? I think a lot of people are very silent today. Vanita? Vanita, can you? Janani?
Sir, the nucleus are often anenucleae and papillary projection like thing in histopathology, papillary carcinoma.
What are Samoma bodies? What are microcalcifications?
Yes, sir. Yes, sir. Will be.
No, if no, don't say yes, sir. Please tell me what are Samoma bodies.
Sir, sir, I'm not sure, sir.
Ajit, Saurav, you are taking exams. What are Samoma bodies? What is orphan nucleus?
Sir, in papillary thyroid carcinoma, there will be large nucleated cells that will look like eyes.
Yeah.
That is orphan ani nucleus. Sir, Samoma bodies, I'm not sure, sir.
Calcifications.
Okay, I'm not sure. I forgot.
Dystrophic calcifications that you see, Dr. Balakumar has pointed out. What is dystrophic calcification? What are the types of calcifications? Do you know? What is metastatic calcification? What is dystrophic calcification? I think you should look up all these things. Okay, so if, for example, let us say this left hemithyroidectomy specimen comes back as multiple micropapillary carcinomas, Ajit, what is the future course of action?
Sir, we'll go for completion thyroidectomy, sir.
Always? Or can you observe? In other words, what is the prognosis of a patient who has been observed as opposed to a patient who has gone through with a completion thyroidectomy? And what will you do about the lymph nodes now that you know that this is a papillary carcinoma of the thyroid on the left side?
Sir, modified radical neck dissection, sir, if the lymph nodes are palpable.
No, it is not palpable. Here you have said clinically known lymph nodes were palpable. It's only a histologic surprise.
Then we can observe, sir.
What about Saurav? What do you think?
Sir, here again that masses and ages criteria can come into play, sir. Based on based on risk stratification, if a patient comes into high risk, we have to go for completion thyroidectomy plus modified radical neck dissection, sir.
Correct. I think that
is central neck dissection, sir.
That is the correct answer. So I think that is where what Dr. Gurushantapa said just now, in terms of the grade of the tumor, the age of the patient, the size of the nodule, size of the tumor, and the extent of surgery that you have done. So ages and AMS gradation. So you use that and stratify the risk, and then consider if it is a high risk group, then you should go for a completion thyroidectomy, and in addition do a so central node dissection on both sides, or so modified radical neck dissection on the left side and a central node dissection on the right side. Sir, Gurushantapa sir, what is your view, sir?
Yeah, what he said, I wanted to know from whoever said this, like, what is the age criteria for a male patient in this criteria? What is the age taken, upper limit of the age?
Sir, 40, sir. Anything above 40
For
years.
male. For a female? For a female patient?
For a female patient,
It will be
both the sexes?
No, sir. Females, the risk is lesser, so maybe more. I don't know, sir. I forgot.
Sir, females 40, male 50, sir. Male 50.
Pardon?
A male 50,
Pardon?
female 40, sir.
Oh, is it, or is it the other way around?
Sir, in that Makanlal's, it is given 50,
yeah,
sir.
Which sex is more prone to have a malignancy, thyroid malignancy?
Sir, females.
Sir, by frequency, female, sir. Sir, by total frequency, females are more
thyroid
frequent.
nodules.
Oh, thyroid nodules are males, sir. Males.
Okay. If there is a solitary nodule in two patients, one
Yes,
male at the age of 40 and one female at the age of 40, who is more likely to have a malignancy?
Some male, sir.
Which patient? Male?
Some males.
So age
yes,
criteria, it is lesser in male age group.
Yeah.
Yes, sir.
40. And
40
in female,
male,
earlier it was for 50 years. As far as my knowledge goes, now it is extended up to 55 years.
Okay, sir.
According to American Thyroid Association guidelines. Please correct. Lakshman sir, you can correct me if it is something wrong here.
I don't actually remember the exact cutoff, sir, but I agree that it's more common in males than in females.
Females, yeah.
And we need to look up the criteria.
For a male, it is 40.
Yeah, from time to time, we must refer to the books for getting the exact figures for these criteria.
Dr. Balakumar says it is 55 years. I think he concurs with Dr. Gurushantapa.
Now, earlier it was 50 for a female. Now it is extended in a female up to 55 years, and a male it is 40 years.
40 years.
So that is the criteria you should take. And the second point which you mentioned, Ravishankar has given an option of a papillary carcinoma, and it is microcarcinoma. So that's the scenario he gave. So what is that microcarcinoma? If he is talking about microcarcinoma, when do you say it is microcarcinoma, papillary carcinoma in a histopathology? Ajit?
Sir, less than 1 centimeter diameter, sir.
Okay.
Micro and
specimen,
more than
histopathology.
Yes.
Histopathology. See, now we have a case presented as solitary nodule thyroid. You got a histological surprise of micropapillary carcinoma. Clinically, it is N0. On imaging, it is N0. You have done a hemithyroidectomy in a male patient. So, if your plan is to do revision total thyroidectomy, so for papillary carcinoma, including central neck dissection is not an accepted way of the information. In a N0 neck, if you are planned to do either total thyroidectomy de novo in the first instance itself, or if your plan is to do a revision total thyroidectomy, central neck dissection is advisable only if the histopathology is medullary carcinoma thyroid. So in a micropapillary or a papillary carcinoma for a revision total, I think the answer, the accepted answer would be revision total thyroidectomy. Okay, in a N0 neck. Sir, Lakshman sir, if anything.
I totally agree, but I would like the postgraduates to reason it out. What you have said is perfectly right. Why are we saying this? You don't need a neck dissection in a papillary carcinoma versus a medullary carcinoma. Why are we saying this? The answer is that medullary carcinoma is neither TSH dependent nor is it responsive to radiation therapy or radioiodine or whatever. Whereas papillary carcinoma responds to the TSH suppression, and if it comes at a later stage, for example, in beating this suppression, then it can also be tackled with radioiodine because they are a differentiated cancer. And so the overall survival is not affected by dealing with the lymph nodes in a differentiated cancer like papillary carcinoma. Whereas if you do not, the only treatment for medullary carcinoma is surgery. Nothing else touches it. And so when you do it right, when you want to get it right the first time and be radical with surgery. That is the logic. Okay?
Yeah.
Right.
Sir, since we are discussing about medullary thyroid, sir,
Yeah.
that MEN 2A and 2B syndrome is there, sir.
Yes.
Sir,
No, but that's a different thing. Whenever there is something called medullary, you got to look for these syndromes.
yes, sir.
Automatic, okay? But let it, no, it's getting to be 10, so let us not get into it now. But let's.
It is very rare, so I don't think we need
Yeah.
to worry about.
Okay, sir.
So so are you very clear? If it, clinically there are no palpable nodes, and if the histology is only micropapillary carcinoma, then you do, if at all, you can do a completion thyroidectomy. I think the literature supports the fact that you can also observe these patients and then do a completion thyroidectomy as and when required. But there is a school of thought which is now advocating total thyroidectomy in all cancers, especially papillary and follicular, and of course in medullary also. So I think Guru Shantappa sir, what is the answer you expect of the students if it is if it is microcarcinoma with no palpable nodes? You found a surprise in the histology. Do you expect the students to go back and complete the thyroidectomy or observe the patient, sir?
In this patient, since the patient is male and
Yeah.
age is, they said, I think 45.
45.
45.
Yeah.
Yes, sir. 45.
Yeah.
Yes,
So straight away, you should we should be expecting revision total
Revision
thyroidectomy
total thyroidectomy.
for this patient, irrespective of yes, revision total thyroidectomy.
So this ages criteria, because the size of the nodule is big, patient is a male who's more than 40 years of age,
Male.
and depending on the grade of the tumor also, so you certainly go ahead and do a completion thyroidectomy.
yes.
Okay.
Sir,
So now,
I have one last doubt, sir.
yeah.
Sir, regarding that radiation, we asked in the history of radiation in the past.
Yeah.
So how means how long should it have been like to develop a cancer?
Usually is childhood
Ajit,
irradiation.
you should be answering this, no?
Sir,
Yeah.
no,
Ajit,
sir.
you
Actually,
should be
we had, sir, in with HOD, sir, we had this discussion, sir, in last year when we presented clinic. So one time we were like confirming it from you, sir. Hello.
the minimum time required is 10 years, what is mentioned in the books.
Yes.
So in the past, radiation to the neck, head and neck area during childhood, it takes minimum of 10 years. So anywhere beyond 10 years, person can develop malignancy, and the commonest malignancy they are going to develop is papillary carcinoma.
Papillary, yes.
Papillary carcinoma. Yeah.
So
Okay,
10 years, minimum of 10 years.
Okay, sir. Thank you, sir.
One more entity, not only head and neck irradiation in the childhood, there is a for hematological malignancies where the bone marrow is irradiated for some hematological malignancy,
Yeah.
which arises in the bone marrow. That also is one of the predisposing factor for developing malignancy, thyroid malignancy.
Okay.
Okay, sir.
So I think again, we have fallen short of time in terms of discussion. I think there are still a lot of things that we need to discuss, but I think it's now 10:05, so I think we will stop the discussion here. Dr. Guru Shantappa, final comments from you, sir, and then Dr. Lakshman.
Yeah, it was nice. This thyroid disease is the one where there is no end. Like if they have a good knowledge,
Yeah.
and if they are really interested, you can have a good discussion. And
Yes.
I tell my postgraduates, thyroid diseases are like mathematics. If you know the background, there are already standard protocols you need to follow. That's all. Not like
Yeah.
CA breast. Whatever you do may be wrong. Whatever you have not done, that may be also may be right. So, but thyroid, everything is standardized. So if people know, nice things can be discussed and done as a treatment.
Okay. Dr. Lakshman, sir?
Yeah, I think it was a very nice discussion. We must thank you for conducting it very well, asking the right questions, and Dr. Guru Shantappa for giving some very focused insight into what is expected and what needs to be done. But my appeal to all the postgraduates is that, sorry for using this word, that you blurt out some answer when a question is asked. You must resist that. I'm repeating it 3 times. When a question is asked, please remember that everything that you say, I have put it in the chat box, everything that you say must be defended. So you think of the defense first. Take 10 seconds, pause, and then give the answer. Don't straight away, total thyroidectomy, sir. We'll observe, sir. We'll do this, sir. We'll do that, sir. No. Please think about it and answer, because you will have the answers, and you must expect the examiners or whoever who's evaluating you to ask you, why do you say this? So please think of the defense first and then answer. Thank you.
Thank you. So, Ajit, you presented the case well. Important, to take a proper history clinical examination is extremely important. Investigations have to be focused, and you should know the exact indications for each investigation. And then you should also know when to operate, why you want to operate. You should be able to convince the patient the operation is the right choice for them. And then you should know the steps of the surgery, the complications related, and then future course of action in case you find surprises. So all of you kindly read up, and if it is required, we will have one more class on the other aspects that have not been covered in this class. Thank you very much, and for all your active and active participation. Good night.
Good night. Thank you.